Recorded for folks who can't be with us today. So folks online, I encourage you to use the chat, mute until there's a time for discussion. And then of course, you can chime in. And just a reminder, don't put any private information on there as we're recording for today. And next, I'll just do, oh, the slides are about to advance. I'll just mention that, so I'm here from Vancouver, BC, Canada. We like to do an acknowledgement to the Indigenous lands that we get to live, work, and play on every day. So, and a number of us from the folks that support the Hip Hop Network work out of the same site. So we're happy to acknowledge the unceded and traditional territories on which we get to live, work, and play. So those are the ancestral territories of the Musqueam, Tsleil-Waututh, and Squamish nations. And today, here in DC, it's the Piscataway Conoy ancestral territories that we're on. So we'll acknowledge that as well. And we invite anyone to reflect in a similar fashion from where they might be, because we have guests from all around the world. So with that, I'm going to invite Dr. Kishore Mulpuri to come up and kick us off.
Good afternoon, everyone. Thank you all for being here. And I sincerely want to thank those that are joining virtually as well. I bet you're joining at all different time zones, and truly this is a global network. So we appreciate all of you being a part of this conversation. This as a concept came about, I think, 2015, 2016, when talking to Emily, we were part of this, lots of these study groups, some were leading, and there's not a congruence in pediatric hip, and a lot of the common problems in terms of whether we look at shape or whether we look at AVN, we're discussing in different study groups, but not all together. And also Colin Mosley, I'd like to recognize his kind of vision when we're initially starting about this network. And I think his encouragement saying, look, I think this is very much needed. I think pediatric hip needs a focus, just like there is some for spine and for ASCPDM and for limb deformity and others. And I think we do need one. So I just want to leave with that. There's amazing work the team has put together. And now Alric is going to chair. He's been one of our pillar leads that's been there from inception. And I'll formally acknowledge, but I think, we would start with really giving a big round of applause to Tamara and Joel that actually put all of this together, especially Tamara, who's done an incredible amount of work for putting this together. And so I'd also leave you with a thought, and we'll talk more about it. I think this is going to morph into a pediatric hip society with a standalone meeting at some stage, and we'll discuss about that a little bit later on. But I'd invite now Alric, who is currently the president of Pediatric Orthopedic Society of India, who's been an incredible friend and someone that we've collaborated on a lot of different projects with the concept of local to global, back to local. So thank you, Al, for being here.
Thanks, Kishore, my friend. It's great to see so many of you here this morning. I know many of you have come from different parts of the world. It's great to meet old friends and to meet and make new ones. The number of people that we have been interacting with on Zoom, and it's nice to put a face to that name that we saw on the Zoom chats. So as you can see today, we have a really busy agenda, and I think on each table you might have a copy of the agenda put up for you. And we're really going to stick to time here because we have a lot to get through. Right at the beginning, I'd like to acknowledge, of course, my friend Kishore and Emily, of course, who many years ago decided to come up with the Hip Hop Network. It was this sort of thought that was in their minds. And I always remember a wonderful saying which says, always remember to fall asleep with a dream and wake up with a purpose. And that's what Kishore and Emily did a few years ago when they said, let's get all the pediatric hip experts together on a single platform. And that's where we are today. I'd like to acknowledge all of my co-pillar leads who are here today as well, and the wonderful team who has been doing all the hard work behind the scenes, Joel and Tamara. So as you can see from this program, today we're going to do a lot of stuff. We're going to have some speakers speaking about some rare hip conditions, specifically spinal muscular atrophy and trisomy 21. We have about 9 or 10 then late breaking abstracts, some interesting topics from across the world. We'll have a little break in between then, and then we'll come back for a wonderful session where we are hoping to all sit together in breakout groups that you can see at the four corners of this hall. And each of the pillars will take you through what we have achieved so far and where do we plan to go in the next year or so. So that's the breakout activity that happens after the break. And then we'll regroup again for some late breaking abstracts again, and then a little bit of wind up with a group photo. So thank you everyone again for being here today, and we're going to have a great time over the next few hours or so. I'll hand over now to Emily, who's going to talk to us about the Rare Hip Conditions Registry. Thanks, Emily.
Thanks, Al, and thanks everyone for being here today, either in person or joining us over Zoom. It's incredibly gratifying to see this starting to come together. I won't be up here speaking long. I just wanted to introduce the concept of, as we've talked about at previous meetings, the Rare Hip Conditions Registry. So we have sort of big registries sort of covering, or big study groups that are covering with IPSG, covering Perthes. We have our Global Hip Dysplasia Registry, our SLIP Registry. But there are all these other hip conditions that are comparatively more rare in certain parts of the world that we really need to come together as a group of experts and really pool our collective brain power, our collective patient populations to really start to answer some of these questions on these conditions. And that's where the Rare Hip Conditions Registry was born. And we're getting started with a couple of conditions under the Rare Hip Conditions Registry, the hip in spinal muscular atrophy, as well as the hip in trisomy 21. And so it's my absolute pleasure today to introduce first off, Drs. Evelyn Kwong, Dr. Jason Howard, who are leading the charge on the spinal muscular atrophy portion of this. And so I'll welcome them up here to give their talk.
Thank you. Are you going to be, are you running this, Joel, or tomorrow? You are, okay. All right. I can't actually see what I'm talking about, but that's okay. So the Rare Hip Registry, I think we were really excited to be involved with this, kicking this part of the Hip Hope Network off. And I'm excited to work with Evelyn Kwong and Yanis Wong, who's here today from Hong Kong, on this with their experience. But I wanted to tell you a little bit, just a short introduction to why we should care about the hip and SMA and why we should have it as part of our Rare Hip Registry. So spinal muscular atrophy, we know is at least in my world, a fairly common neuromuscular disorder. Other than Duchenne muscular dystrophy is most common diagnosis we see in our neuromuscular clinic. And it's progressive disorder with involvement of the spinal cord anterior horn cells. Next slide, please. And, the survival motor neuron protein is the gene product that is responsible for the phenotype, particularly encoded by SMN1 gene, which is the defective gene in the disorder. But the SMN2 gene also does encode for SMN protein, though to a much lesser extent. And the number of copies of that gene are linked to the phenotype in a positive way. Disease-modifying agents which affect gene splicing of SMN2 or replace SMN1 have really changed the paradigm for this disorder in the orthopedic world. Next slide. And particularly with respect to the hip, I think we've been fairly satisfied with our approach to the spine for the most case, but hip instability has been a subject of controversy. And if you look back through the literature, There's, the studies that are there have been very variable in their outcomes. And it's really led away from doing proactive orthopedic management in this disorder. But the onset of disease-modifying agents, which is improving function, improving perioperative outlooks, has really made us take a second look at these disorders, particularly as we're seeing, at least anecdotally, as these kids get more functional, they also seem to be becoming more painful and having more problems with positioning related to the hips. Next slide. And so I think we just said that, right, about the disease-modifying agents. And this is really what we want to avoid. This is a child who had no hip surveillance, came to our clinic late from outside, and he's 13-year-old type 2 SMA, very smart young man, but in serious pain. I mean, he can't sleep. The only option really for him now is a salvage type procedure. So should we be more proactive in these cases to avoid this situation? You always remember the worst cases. And you tell me, well, I have a whole bunch of them that are doing just fine. But I think in this new age of the disease-modifying agents, we really don't know what the landscape holds. So we need to get a better handle on that. Next slide. Okay, you can keep going. There's only 2 papers that I know of that specifically look at hip pain and SMA. That's one from Johns Hopkins there. We show the prevalence of hip pain to be quite high, although not all are severe. And they've got some risk factors there. Next slide, please. And this one by Matt Halansky's group, which shows prevalence was related to the number of SMN2 copies and whether or not you had scoliosis surgery. You can go again. So we wonder if this higher function that they saw in SMN2 copy number, seeing more hip pain, will our higher function with disease-modifying agents also cause more discomfort and problems? So we wanted to look at the risk factors for that. You can go back one if you don't mind. So at DuPont, we looked at our cohort. We had 82 patients who met our criteria that actually had hip surveillance x-rays. And we looked at risk factors that you can see here. Next slide. And most, I wanted to really focus on the functional scale. So not only radiographic things, but also about function as a risk factor. And Evelyn's going to talk more about that. Next slide, please. We found the prevalence to be quite high for 1 and 2. See, it's 80% in both 1 and 2, and a little lower in type 3, but still about 36%. And if you just click along there, so you see the age of onset is also related to SMA type. Next slide. We looked at risk factors. Just give it a little click there. And, by univariate analysis, all of the risk factors came out to be associated with hip displacement. But if you click again, you see that there's only 2 independent risk factors: scoliosis, whether they had scoliosis or not, and type 2. And that may be related to function. If you click one more, interestingly, disease-modifying agents did not seem to prevent it and were associated with an increased risk of hip displacement, which maybe goes along with that hip pain and things that the Halansky group found. Next one, please. And keep going. So should we treat hip instability? Should we even look for it in SMA? I believe we should, but I don't think we have all the information yet. We know some risk factors. Prior studies have been controversial, and we don't have any studies really in the era of disease-modifying agents. I think this one and Evelyn's have been really the first ones. There's a couple more coming from Turkey. So this disease-modifying agent treatment they're important, it's influential, patients are stronger, they're more functional, but are they getting worse? Certainly they can better tolerate the surgeries. Next one, please. So we want to avoid this type of situation. Just click along there. This kid who had arthritis and pain and got better after VDROs, but should we be more proactive for these kids, or should we be reactive? You can go one more, please. With respect to hip surveillance, if you want to be proactive, you got to pick them up. And, I think for SMA, with respect to the criteria for hip surveillance, we meet most of those criteria. With maybe the last one, number 5, there should be a safe, effective, minimally invasive treatment. And we're not sure if we have that yet, but perhaps it could be guided growth. There's really no studies on that as of yet. So next slide, please. So we have some guidelines, which as a starting point, and we hope to refine those through this group. And next. And so I hope I made the case that there is a case to be made for SMA as part of our rare hip registry. We know prevalence, we know something about risk factors. We know that some of them have pain, but we don't really know how many, who has it, when they get it. Should we be proactive, reactive with our operations? What operations should we do? We know that disease-modifying agents make people better, but do they make the hips worse? And I think our registry is a way to start to answer some of these questions. But to do that, we need input from our members, and we need to have the right data that goes into the registry, or else we've got garbage in, garbage out. And we've seen that in other registries. You know, we don't want this to be just a radiographic registry. That's not enough. We have an opportunity to do things better that way. And Evelyn's going to talk about some of those data elements.
So you've seen the disease burden. Hip instability is actually a problem. And the reason why we need to have a hip registry is because it's a changing landscape. SMA1 patients used to look like this. They used to die when they were toddlers from respiratory failure. But now with the invention of disease-modifying agents, which was first published in 2017, not only are they not dying, they've got improved motor scores. And so now SMA1s look like this. So this is one of our kids who received nusinersen when he was 3 years old. And they're not dying, they're not on mechanical ventilation, but they do need non-invasive ventilatory support, but they're sitters and they've got good head control. And so they now actually show up at the orthopedic clinic when they never did before. SMA2s used to look like this. They used to be sitters. They never walked, they never stood. They had really bad neuromuscular scoliosis. You had to do long fusions for them. The hips did come out, as Jason showed, but we never really were very active about them unless they dislocated and caused pain. But now, with disease-modifying agents, SMA2 patients look like this. They can walk. So it's not normal walking. It's a lot of waddling. They're indoor walkers. This kid can at least go to the bathroom by himself now, but they're not wheelchair-bound all the time. So this is the strongest case for hip surveillance and a registry because these disease-modifying agents do allow these kids to now walk. Okay. So with the disease-modifying agents, are the hip subluxation incidents going down? Is it improving? So their motor scores are going up. They're walking now. They're not sitters anymore. But you can see from the title of the paper we just published in JPO, it's actually not good news for the hip. We managed to follow these kids prospectively from 2018 when this drug was approved in Hong Kong. And from just the short 5 years that we've watched them, actually the hip subluxation actually increases. So this is our data. You can see it in our paper from JPO. The upper limb scores improve universally. So they all do better. They can write better. They can control their wheelchairs better. But the lower limb scores, especially when it comes to gross motor function like sitting and walking, they don't necessarily improve for all cases, despite the disease-modifying agents. There's like 12 more slides. So we'll stay here then. So what this means is that despite having disease-modifying agents, these kids are walking better for a lot of them. They definitely have better upper limb scores, but the hip subluxation actually continues to progress. And what we found is the Reimer's migration index, just that one parameter there, increases with time, despite disease-modifying agents. And so the hips are subluxing with them having better walking skills. And we believe it's probably because they do walk, but they still have a lot of muscle weakness, a lot of muscle imbalance, and they're not normal walkers. As you can see, the SMA2 kid, it's a very waddling gait with severe Trendelenburg. And so that's the case for a registry for spinal muscular atrophy patients, especially now in the landscape of disease-modifying agents. So there are a couple of scores that we really want to gather. For example, you saw here down at the bottom, this is the Hammersmith. It looks very cumbersome, and it's like 35 steps, but it's the Hammersmith gross motor score. And the reason why we want to use this in our registry is because it's physio-based. Your physiotherapist can do this for you. But what it shows us is the progression of these kids. They go from being essentially bedbound to being able to sit, to have head control, and then to stand, and then to walk as well. And we find that all of the papers that have been published since 2017 by the pediatric neurologists actually use this score. And so it's a lot of steps. It's done by a physiotherapist. You'll need to train one, especially for this purpose. You can't do it yourself in the clinic. It takes a bit of time. But it is a very important score. All the papers that are published based on spinal muscular atrophy have the score. And so it's worthwhile, if you do treat these patients enough, to train a physiotherapist to do this for you. There are other scores like the upper limb score that I showed you a while ago. That would be nice if you could have it, but the very basic score that we would like to have is the functional motor score, the FMS, and I think that's easy enough for all of us to collate. And for the x-rays, we would like to look at the rates of scoliosis. We would like to look at the Reimer's migration index, as I said a while ago. We would like to look at the rates of subluxation and dislocation, and of course, your surgeries. Scoliosis, I know this is a hip registry, but scoliosis is a huge part of this problem because, again, from our center, the spine surgeons also followed their rates of scoliosis progression in the era of disease-modifying agents, and they found that in SMA2 especially, there is an annual scoliosis progression of 12 degrees per year. So that's going to be a lot of scoliosis surgery in the future. And of course, we know that the scoliosis is attached to the pelvis, which is attached to the hip. And so it's going to have an influence on what we do for the hips as well. I'm sorry the other 20 slides disappeared, but we can, yeah.
Can I ask, in your experience, when kids have instability, what cellular Hello, this is Salil Lepasny from San Diego. Quick question for Evelyn. So when kids get instability in your experience, what are the characteristics about them that cause them to be symptomatic?
So interestingly enough, we don't find pain so much. So Jason talked about how a lot of these kids dislocate and they get a lot of pain, but it's probably when the hip comes all the way out and it's crushing the labrum. What we're picking up now is because we're following them prospectively. We go from something that had a Reimer's index of, say, 20, and then 30, and then 40, and then 50. So it's like your CP hip. You just watch them come out with time. And so what we find is that they're not painful yet, you know, the early subluxers in CP, and they're floppy, they don't have tone issues. So it's not pain that we're treating, but we know that the hips are coming out with time as they get the disease-modifying agents, as they get stronger and they're maintaining their walking ability. And so we feel that it's worthwhile to be more aggressive in keeping their hips in, to do things more sort of preemptively before it comes all the way out. Yeah.
And so they like to sort of say that. I mean, like CP, the kids, they don't have pain when they're young. They get pain when their cartilage really starts to degenerate. And, you know, in CP, it's around age 12, 13, right? So it's a long time before you develop symptoms. And I would say, you know, like the kid I showed was 13 years old. I think it's probably around that same age. Oh, it may be a little bit earlier, depending on how much abductor function they have. I suspect that increased joint reaction force has you know, a big influence on that. But you know, following them up over time, we know with this registry will give us an opportunity to do will really help us answer that question. Because right now we just have cross-sectional type studies, and you know, nusinersen's only been around since 2017. So the kids are young who've had it for the most part. We have a few earlier ones because they've had the very early trials where we are in Wilmington. So we've got some that are a little older, and we've reconstructed a few of their hips because of pain. Again, these are small numbers, so we need everybody to put theirs in, and we'll figure it out, but it'll take time.
And just one last point, if I have time. Do I have like 1 more minute? Okay. So it's also going to depend on the country that you work in and how it's being given to which patients. The patients you see, say, from here, they were all SMA patients who were diagnosed long before these drugs were invented. So say the kids that you saw a while ago in the videos, they were 3 when they got their first dose, and 5 or 7. It depends on, you know, how long they managed to survive. So they have improvement in their motor scores, but it's not normal. But because we found this data, and we, for example, where I'm from in Hong Kong, we found this about a year or two ago, and we presented this to the government, and it was a convincing argument that we need newborn screening for SMA because that's the only time. Newborn is when you should give the disease modifying agent because that gives you the best motor scores. And we found that we've had 3 kids so far just in the past year born with SMA. And the first dose of nusinersen was given within weeks of life, within 3 weeks, within 5 weeks. And they have the best motor scores. They are normally functioning kids who can go to kindergarten and walk around. So they have less hip instability. So that also be a nice comparison. It would depend on where you work and how nusinersen is given, if there is newborn screening and how fast you can give it. So it's going to be interesting to follow that up as well.
Sorry, one quick question. I'm Kate Stanage. I'm from Perth, I'm in Australia. Just regarding screening protocols, I know we don't have formalised ones at the moment, but are you basing yours on CP guidelines, so the Australian CP or the Academy ones?
So you saw the slide from Jason a while ago, and that's something we had in mind. It's going to be very similar to the one from CP, so something along the lines of getting standing or supine, whichever your kids can manage, every 4 to 6 months, and then also spine x-rays, again, depending on their motor function, depending on how well they can walk. So if they're really good walkers, for example, the SMA2s that got nusinersen pretty much at birth, who are normal walkers, we could probably treat them more like the hemiplegics or the GMFCS 1s and 2s, where they don't have to have the x-rays that frequently. So it's going to be something along those lines. Yeah, we want to establish a hip surveillance as well.
Starting point based on their this is based on when the onset of hip displacement was, and their SMA type, their motor function, those sorts of things. And some of it was taken from the CP group, but mainly it's based on disease onset, which is much earlier in SMA. On the hip surveillance 18 months rather than CP, it should be about 2 years, right? So just a little earlier onset to start, and then more frequency in the kids with less function. But you see, it's based on type 1, 2, and 3 there, which, as Evelyn just alluded to, type 2s are not really supposed to be walking. So we have another problem in the way that we classify these children. This classification is really antiquated now in the era of disease-modifying agents, and so we need something better. I know Cure SMA, with that group, we're going to be working on that, and that might be something we can kind of get involved with from our group here as well.
Sorry, we unfortunately need to keep going with our program. So sorry about the slides, Evelyn, but thank you, Evelyn and Jason, for those fantastic presentations. If we have time later, we will take some more questions. We have 2 in the chats, but we will try and get back to those later.
So the whole idea is just to gauge interest. So who here would be willing to prospectively enroll their patients, SMA patients, for this registry? Okay, so Jason, Evelyn, I think you've got quite a bit of an interest. So I think this will be the first rare hip condition registry that will start.
Yes, thanks so much to both of you for excellent talks, as you said. And I also have the pleasure now of introducing our next speaker, Dr. Mahir Thakur, who's joining us over Zoom in the midst of a busy clinic and busy call schedule. So thank you so much, Dr. Thakur, for joining. And we have worked with Dr. Thakur. He is going to take the lead on the hip in trisomy 21. And so Dr. Thakur, please go ahead. We will, Tamara,
can you guys hear me okay?
Oh, it's up here. Sorry.
Can you hear me okay?
Emily, will you be clicking?
Yeah, I can click. Yeah. All right. Go ahead, Dr. Thakur. You can let me know when to change the slide.
Great. Can you hear me?
Yes.
Oh, perfect. All right. Well, thank you very much for the invitation to talk about the HIP and Trisomy 21 and the opportunity to work with everybody in the Hip Hope Network. So thanks, Kish, and thanks, Emily, for getting this common problem that we face into our forefront here with the rare hip disorders. All of us are very familiar with Down syndrome. It is the most common congenital, chromosomal abnormality that we see. And this is the typical scenario. Here we have, we'll stay with the previous slide. Yeah, that's it right there. So these are 3 8-year-olds, all with Down syndrome, all with differing hip pathology. You can see the one on the left of the screen has acetabular dysplasia, subluxated hip. The other one is almost out and dynamically completely comes out. And then you have the last one on the right that has changes of proximal femoral growth disturbance, small epiphyses. So the hip in Down syndrome is a challenge. It comes in various different flavors. And I don't know that all of us are comfortable with what to talk to with our families when it comes to some of these issues. What do we tell them about screening? What do we tell them about management? So let's go over some of these things that we can hopefully try and shed some light on as we move forward with this. So what we do know is hip issues come in various different flavors. Many of them will end up with end-stage arthritis. So probably about 20% of patients with Down syndrome in adulthood will have sequelae of their pediatric hip conditions that they suffer through. And the most common is instability and dislocation. And this is a particularly frustrating condition in the sense that some of them start really early. We know that bracing really doesn't do a whole lot. We have all sorts of different operative interventions, some of which work somewhat, some of which work temporarily, and then some of them have a little bit of a better outcome, but still not perfect. Some of them are just going to have dysplasia. There's a higher risk of ABN with the SCFIs especially. So there's all sorts of hip things that we really are dealing with in this particular population. Can we go on to the next one, please? Thank you. So what we don't quite know for sure is what is the prevalence of the different hip pathologies in Down syndrome? What are the risk factors for instability? Do we think that a screening program would be helpful in early identification of the unstable hips? And then once you do see that unstable hip, how does it evolve? When we see some of these hips, we've all seen the early kids with Down syndrome that come in with bilateral hip instability. And then there is the subpopulation that comes in a little bit later on towards the end of the first decade with more so the unilateral hip involvement. What drives them to be more bilateral versus unilateral? Not sure we have an answer to that. And then once we do identify that, how do we manage it? Again, various different things that we have tried. We have people who advocate the femoral side of things. We have people who advocate the pelvic side of things. Oftentimes it's a combination of the two. When do you do what is somewhat unclear. And even when we do end up operating on these kids, Salil's paper actually was probably one of the most honest and thought-provoking ones, where he had, I think, about 28 patients or 28 hips in 19 patients with Down syndrome. And half of them had complications. About a third of them needed more surgery. So that is kind of the reality of what we deal with Down syndrome. So in a syndrome that is so common, 6,000 births a year in the US, a lot more worldwide. 1 in 700 kids that are born have Down syndrome. For a condition as common as that, even if we consider on average 5% of kids will have issues with their hips, that's still a good number of hips, and we still don't have great answers for that. So I think that is key, and that is ripe for a registry, for us to be able to enroll these kids into the registry for various different treatments and see what works, what doesn't, and potentially come up with better guidelines. Can we get the next slide, please? So things to think about is, I think, probably starting with all patients, we register them prospectively. We can talk about what kind of data we want to collect. I think having imaging data in itself, just like for the SMA population, is not going to be enough, because I don't think that is the whole picture here. The clinical presentation, the comorbid factors, the hypotonia, and some of the ligamentous laxity issues are going to be big in determining where these hips go and how we deal with them. So next one, please. So I think it's important for us to factor all of those things in. And in thinking about how to practically kind of do some of these things, some of the questions become, how do we actually see these patients? Are they coming to us directly? Do we have a Down syndrome clinic that is run either by friends in genetics or in pediatrics? What kind of volumes do we see, and how frequently do we actually see these patients? And then from a what do we do with this perspective, practically, how do we really parse out some of their medical comorbidities and potentially factor them in? Those are all questions that we need to be thinking about. Also, from an outcomes perspective, certainly imaging outcomes are going to be important, but from a PRO perspective, we'll have to figure out how to go through some of those functional scores and validate some of them, and potentially come up with something that is going to be unique for the Down syndrome population. So lots of questions with this particular population. And I am open to any questions, thoughts, and suggestions. Thanks.
Yeah, Jason, go ahead.
Thanks, Mihir. I think you need to manage your schedule better so you can come here next year. Question about I think the most important thing here is about functional scores and trying to figure out who is at risk of hip displacement in Down syndrome. You know, I saw a child yesterday with Down syndrome, and she was very ambulatory, and she danced, and she, you know, was active, and her hips were perfect, her spine was perfect, and her neck was perfect, you know, and she'll probably never have anything besides flexible flat feet as an issue. Mm-hmm. Then you see the other ones on the other end of the spectrum who are non-ambulatory, who have more severe issues related to their cardiac function and other aspects. And I don't know that there's a direct correlation. And in fact, I don't think there is, like there is in like CP, for example, by GMFCS level, because you can see ambulatory kids having hip dislocations and non-ambulatory kids not having it. So do you have any sense of what type of functional score might help us here and what the correlations might be?
That's a great question, Jason. And yes, I will try and manage my schedule slightly better the next time. But
I'm just joking.
No, I would have loved to be there with everybody. I'm glad that Emily and Keish were able to get me on virtually, so appreciate that. But that is the challenge with Down syndrome. We really don't have a good sense of what drives the hip. And that's where I think that the comorbidities and the ligamentous laxity and the hypotonia certainly need to be factored in. Where do we go with this? I think some of it, there is some data that suggests that the functional level may have something to do with it, but I agree with you. I don't think that that is the end all be all of what drives the hip. And again, I'm not quite sure, whether or not the unilateral hip instability or dislocation is very different from the ones that present early that are bilateral. So there's something that drives them. And it probably is going to be a combination of factors, which is where I think that, pooling our numbers and trying to get a sense of what the functional status is, what the ligamentous laxity is, what all of those things kind of together will give us more of a comprehensive sense of who ends up with the unstable hip, whether or not they had chemotherapy and for the leukemia and then ended up with weakness and maybe a slight neuropathy after that, or what have you. That may be some part of it, but the majority of our hips really don't have any known risk factor per se. So two things, right? One is, do we screen? And who do we screen and how frequently do we screen? And how do we screen? So that's going to be the one big question. And that's where partnering with some of our peds folks will come in. But for us as orthopedic surgeons, the question becomes, when you do see someone, what is driving things and how do we best deal with it? So I think there are two big parts to this hip instability in Down syndrome. And that doesn't even touch some of the other less common hip things. But, I think those are the two big things that we really need to focus on. Does that kind of make a little bit of sense? It's a little bit of a rambling answer.
Hi, Alpesh Katari from Oxford. This is a bit controversial at Hip Hope, but there's a lot of patellofemoral instability in Down syndrome as well. And if we're collecting so much data, baseline data on these patients, and we're interested in function, what are the thoughts about including the knees or working our way down?
So I think that will be part of the entire orthopedic exam, which really kind of starts from the neck down, right? We'll look at the neck, at least document what's happening with the neck, look at the hips, look at the knees, look at the overall alignment. And all that will be at least part of that initial intake. And whether or not we kind of continue with that every single time we see them or not, we can talk about. If certainly there are changes, then obviously those will need to be factored in also. When you're spot on in the sense that we cannot just look at the hip in isolation. When you look at this paper that talks about the global health measures with the National Down Syndrome Registry, that's exactly what they pointed out, is even when you look at the overall health picture, it's not just going to be one system. So we will probably need to be somewhat comprehensive with our initial data intake, because we'll have to include things like cardiac status, things like that. What is their walking ability? So it's going to be a little bit of a more comprehensive look at what the overall health of these kids is and whether or not that actually influences their hip instability, which is what the suggestion has been without necessarily having any hard data to support that.
Thanks very much. I think, okay.
Uri Givon from Israel. I wanted to ask if you have experience with the combination of T21 and cerebral palsy, because I have 3 or 4 of these patients who were born prematurely, and this combination somehow created the most challenging hips I had to struggle with in my career. So I want to know if you or other people have the same experience.
Hey, Uri, it's good to hear from you. We certainly have kids who have the combination. I think it is from a couple different things. One is certainly if they're premature and they have changes perinatally, that will do it. The other thing that gives you a very similar picture is some of them actually end up with vascular issues in the brain. They are at risk for moya. So there's some of that does get into the neurologic side of things. we also have one patient who actually ended up with hemiplegia after a spontaneous internal carotid dissection. So there's all sorts of neurologic other issues, not just perinatal things, that can give you similar pictures and then can complicate the hip side of things. So that's why I think looking at the overall big picture is going to be important with dealing with the hip.
Thanks very much. Thanks very much to Dr. Thacker and for our previous speakers.
Yeah, just on show of hands, who might be interested if there was a registry for trisomy 21 for hips? Okay, so we've got quite a few people. So thank you.
Thanks very much, guys. Feel free to email me, touch base with me, and we can talk about this more. Thank you so much.
Thank you. And in the interest of time, keeping things moving, we're going to move on to the late breaking abstracts part 1 section of our agenda. So my co-research pillar lead, Woody Sankar, and I wanted to sort of see put out a call for late breaking research that maybe missed the EPOSNA deadline or was very, very niche, hip specific. And we are very, very grateful you answered the call. We have an exciting lineup of abstracts to be presented today. So without further ado, I'll introduce our first late breaking abstract speaker. It's going to be Mr. Jal Baraza from Aga Khan University Hospital in Nairobi, Kenya. And he is going to be presenting varus derotation osteotomy of the proximal femur in neuromuscular children using a locking plate, surgical technique, and initial results. Wait, Jal, here's the advance. And so move forward and back, and you can see.
Okay, thank you everybody for the opportunity. Thanks, Emily, for the introduction. I work in Nairobi, Kenya, and I'm going to speak about a novel technique and our initial results using a locking plate for VDRO surgery. Those are my affiliations. So VDRO surgery is normally undertaken using a blade plate in the normal fashion, medial closing wedge osteotomy to improve the coverage and containment of the hip. It has a long track record. It's predictably effective, but it's not always available. Certainly when I went back to work in Kenya, the blade plates were just not there. And I was told that part of the reason they're not there is because they're very expensive compared to some of the more conventional implants. And the blade plates also in the smaller hips can, there's a high chance of iatrogenic damage because sometimes the femoral neck diameter is quite small. So we wondered whether using the implants that we do have available, such as the small fragments, 3.5 millimeter locking plate, if we could perform this operation because we do have it, it's cheaper, and because the diameter of the screw is only 3.5 millimeters, you're less likely to get in trouble when dealing with the femoral neck. There is a learning curve, however. So I'll just talk about the technique first and then present our results. The initial 2 millimeter KY is driven up the neck. These hips, as you probably know, are in valgus. So getting that angle is a bit tight. On the AP view, we want to err a little bit superiorly. And that wire is used to control the hip and also as a guide to the plate. So after drilling the K-wire, we slide the plates on and then just distal to the second hole of the plate. So around the top of the third hole, we mark the top of the femur with cautery, and that'll be the proximal limb of our osteotomy. So that's the horizontal limb. The plate is then taken off. We perform the osteotomy in the standard fashion. So the proximal cuts horizontal and the oblique cuts distal to it, ensuring we don't go beyond our cautery mark. And then the plate is placed on and held initially to it's first contoured, and that can be a little bit challenging, holding the plates adjacent to the bone. But after we achieve that, we hold it with a locking screw through the second hole. So it's important that that second hole is not interfered with, is not tampered with in any way. Otherwise, you might find yourself in some trouble with the locking mechanism. After attention to the version and coaptation to the bony surfaces, it's then held onto the shaft, and then the initial 2 millimeter KY, which was used as a guide, is replaced with a cancellous screw, and often the hold is quite good. Post-op, and we actually do the caudal block pre-op to reduce anesthetic requirements and hip spike in the usual fashion for 4 weeks. And usually 2 nights is the maximum they stay. We used to use epidurals, but they're a bit fiddly epidurals with a hip spiker and anesthetist going to check. So these days, caudal blocks work perfectly well. We wanted to find out whether this method was actually helpful. So we conducted a little study using the well-known parameters, Reimer's migration percentage and Astabler index in those patients who required a day osteotomy. And these are just a run through of some of the patients. This patient unfortunately passed away. The parents called me a couple of months ago. He is GMFCS5, very sad, but they were thankful that we relieved his pain and treated him well. Where I'm from, many of these conditions still have a lot of stigma. It's not unusual for the parents to actually hide the children at home. The only time they come out is when they come to the hospital. So that's probably another discussion for another topic. This was the second patient, third, and the fourth. So there were 6 hips in 4 patients. And on analysis, we reduced the Reimer's migration percentage from 64% to 23% with a p-value of 0.026 and a follow-up of 8 months. And for those that had a pelvic osteotomy, which is the Dega variety, we reduced the Astabler index from 33 degrees to 23 degrees with a p-value of 0.013. Statistics, we used the paired t-test for non-parametric data to determine the statistical significance. This method there's a lot to think about compared to when doing a blade plate. Once you get used to the blade plates, it's actually a joy to do. Used to do them quite a bit during fellowship. When I went back home to Kenya, because of the absence, you realize there's a lot to think about. After the osteotomy is made, one has to contour the plates, which can be a frustrating process. It's very helpful to have an assistant who knows what's happening and who's switched on, because variation of holding the bone surfaces co-opted may lead to difficulty in contouring the plate. Limitations of the study and of the technique, I lump them together. It's the radiographic parameters mentioned are surrogate outcomes. Pain and function would be more useful. All the patients were GMFCS 3s and 4s. Sorry, GMFCS 4 and 5. So it's not always easy to gauge the pain levels, but in all the patients function improved. That would have been good to measure in terms of range of motion of the hip. Recurrence, this is not really, the osteotomy site takes 6 to 8 weeks to heal and probably another couple of months to mature. So it's not really a limitations of the technique, but probably just of the condition. There is a learning curve and it helps to do the operation with the same assistant. We have variable follow-up. Where we work, patients often come from very far away, sometimes out of the country. And once they're treated, or once the parents see that the child has been treated for the condition that came in, they disappear. No way are they going to travel for a whole day at a great expense to tell you everything is okay. So follow-up is sometimes an issue. And there are also other non-surgical factors that go into a successful operation, which probably were not accounted for in this study. In conclusion, if you ever find yourselves in an area where the blade plate is absent, a lock-in plate adequately contoured can be used as a substitute. Thank you very much. I invite questions.
Jal, great technique. And I'd suggest you chat with, I think, Rujuta and Al that use a lot of similar kind of technique in India when you're done. So in the interest of time, we're going to move forward for the next presenters. Your 7 minutes include discussion time. So if you don't save enough time, we're just going to move to the next presentation. You can discuss during break. Thank you.
Great. Thank you. Thank you, Jal. And so, yes, next up, we have Dr. Suzanne DeVos Jacobs giving her talk. She is from Erasmus and Sophia Children's Hospital in the Netherlands. And she's going to be speaking on assessment of hip reduction with serial transinguinal ultrasound during hip dysplasia treatment, preliminary results of the RETURN study. Welcome, Suzanne.
Okay, so thank you for the introduction and for the opportunity to tell you something about my research. First of all, a great thanks to my team, because without Jaap, Hester, Max, it wouldn't be possible to present you this. So I've got another title slide. And of course, I would very much like to thank EPOS for rewarding us with an EPOS grant. So to make this study possible. So first of all, we all know that the Pavlik treatment is used for the treatment of unstable hips in DDH. But there's also in literature a percentage of 20 to 40% where no concentric reduction is achieved using the Pavlik harness. And if we treat the hip too long with a Pavlik harness, then there's, why are my slides advancing? Let me see. This is not, that's just showing. Yeah, but it's just advancing by itself. Oh, so, well, there's a risk of AVN or acetabular impairment if we treat too long with the Pavlik. So that's why we thought that we needed a study to determine the optimal time frame for duration of treatment with Pavlik, because a lot of guidelines, they say we need to treat for 6 weeks or for 8 weeks, but there's not really a study that tells us what time is optimal for treating a dislocated hip in Pavlik. So what we did is that we started a study with 50 children aged up to 6 months with a graft type 3 or 4 hip. And we started Pavlik treatment just as we should do when they're not included in the study. But then we follow them up with a weekly transinguinal or anterior ultrasound, which is made while wearing the Pavlik harness. So I will tell you a little bit more about this technique because it's not yet widely used. So in a frog lateral approach, in a frog lateral position, like the position in Pavlik or in spica cast, you have an anterior approach of the hip using the ultrasound, and you can assess the depth of your femoral head and neck in relation to your acetabulum. So on that way, you can see how your hip is in place or not. Now, I see that this image is really tiny. It was a large image, but I don't know if I have a pointer. Yeah, I should. So what you see, oh, I can't use the pointer when I'm standing next to it. Here you can see, oh, now this doesn't work. I'm sorry, but my image is too small and now all my drawings are not on the correct place in the image. So this is not going to work. Well, I'll just improvise. First of all, on your ultrasound, you're going to look for your pubic symphysis. It's very recognizable, and I hope my next slides, the images will be fine, so I can show you in real ultrasound image. So you look for your pubic symphysis, then you go all the way lateral, following your pubic bone until you get to the acetabulum. And then in the acetabulum, you can see the cartilaginous femoral head, but most of all, you're looking for the metaphysis of your femoral neck. And here you can see what it looks like. On the right-hand side, you see a schematic drawing of the image that you see on your ultrasound. On the left-hand side, you see the ultrasound image. So here, there's your pubic bone going down into your acetabulum. And on the left hand, the right line, the red line is showing your femoral neck. And this should be in the same plane. So it should be like some smooth, straight line. And that's when the hip is in the correct position. If you've got a dislocated hip, here again, my image is shifted. But you see on the right-hand side, you see your acetabulum. And on the left-hand side, you see your metaphysis of your femoral neck. And this is all the way down. So this is not in the same plane. It's shifted down. That means that your hip is dislocated. Here you've got some images of how the ultrasound is performed. So first of all, you look for the pubic symphysis, and then you go all the way lateral to search for your acetabulum. And here is a video of what it looks like on your screen. Here you see your pubic symphysis, and then you move to the lateral side to following your pubic bone, and you look for the acetabulum. So here you see the image of your acetabulum. So your acetabulum is on the left side, and then you see your cartilaginous head and your metaphyseal bone on the right-hand side. And here it's just in the same plane. But the good thing about this ultrasound, which is done in the OR, is that you can see what it looks like when the hip is correctly located, and here the hip is dislocated. So you really see it disappear in the depth of the tissues. So our preliminary results are of 20 children with 24 dislocated hips, 83% female, 67% left-sided, and the average age was 20 weeks at treatment initiation, where the most kids had a graft type 3 hip. We had a direct reduction in 7 kids. So directly when we put them in the Pavlik harness, the hip was directly repositioned. And we had 15 hips repositioned in the first 3 weeks and 2 more hips reduced in the last week, the 6th week of treatment. So we have 71% of successful reductions in the Pavlik harness in 6 weeks. And of those 17 reduced hips, 88% was reduced in the first 3 weeks and 12% in the succeeding 3 hips. But of the 12%, so of those 2 hips, 1 hip remained unstable and needed spica cast after all. We found that a higher age at treatment initiation led to lower chances of success. And there was for now no difference between graft type 3 or 4, but up to now we only included 5 graft type 4 hips yet. So maybe this will change a little if we reach the number of 50 included children. So to conclude, the likelihood of successful reduction is the highest in the initial 3 weeks of Pavlik treatment. So 63% of the hips are reduced in the first 3 weeks, and a total of 71% is reduced after 6 weeks of Pavlik treatment. And the higher age at treatment initiation leads to lower chances of success. So thank you for this opportunity. Do we need a mic?
Yeah. I think it's been 7, so we're a bit behind in our.
Oh,
schedule.
okay.
Sorry.
I thought I had some time.
Sorry. All right. And so next up, we have Dr. Alaric Regis from Baijabai Wadia Hospital for Children in Mumbai, India. And he is going to be presenting on developing screening guidelines for DDH and CP hip displacement for a 1 billion+ population. Lessons learned. Take it away, Al.
Thanks, Emily. So this isn't really late-breaking abstract as such, but more of sharing with this group out here some of the efforts that we have made in developing guidelines for DDH screening and CP hip surveillance in India. I think this is a very important quote that I believe is really what encompasses all that we've been doing over the last few years, mentioned by Thomas Edison. I don't need to really preach to the clergy here, but I'm sure all of you are aware that we have several national and regional hip screening programs for DDH and for CP across the world. And there's a standard of care globally. It's been shown that there's a marked reduction in the incidence of late presenting DDH and salvage procedures for hip dislocations in CP. But we must understand that many of these programs meet the needs of the local populations and the healthcare systems that they've been designed for, and may not always be transferable to developing countries, especially countries like ours in Asia. We know that many of these guidelines are not very applicable to our population because there's a very poor awareness about the need for screening for DDH and CP hip surveillance among pediatricians and allied healthcare professionals. In India, unfortunately, we have this very strict preconception, prenatal diagnostic acts, which restricts the use of ultrasound in pregnant women in order to sort of balance the skewed sex ratio. And therefore, ultrasounds are not easily available throughout the country. Most of the centers, the primary health centers, would have ultrasound, but they're not freely available for use. Furthermore, we know that if children get through screening, there is no structured surveillance to detect late cases. And we didn't really have any pathway even then for referral after the initial diagnosis was made. I don't need to belabor this point. India's the most populous country in the world now, something we're not very proud of, with the annual number of births of 26 million. And assuming incidence of 1 in 1,000, we can presume that there are almost 26,000 children born with a hip dislocation every year. And with a 35 incidence of CP, we have a very high incidence of hip dislocations and cerebral palsy as well. We have a very skewed healthcare system in India, and we know that less than 1.5% of our GDP is really invested or allocated to healthcare. There's a big lack of infrastructure and shortage of doctors in the rural areas, therefore resulting in a large variability in the equity and quality of healthcare services that we have in India. So a couple of years back, in fact, a little longer, during the COVID pandemic, we decided to use the time on hand to liaise with various different organizations which deal with children's health, especially the Indian Academy of Pediatrics, the Neonatology Forum, the Association of the Imaging and Radiology Associations, and decided to develop pathways and guidelines for DDH and for CP hip surveillance. And I must acknowledge the help of Kishore, Emily, and the entire group from Vancouver, who really helped us out in developing these guidelines. We went through it in a very staged manner in the first phase, where we assembled the expert groups drawn from these various organizations to conduct a scoping review of literature to identify the knowledge gaps. And then moving on to the second phase of the Delphi approach, where there was lack of evidence from literature, to actually try and get some expert opinions on how can we develop guidelines specific to our healthcare system. And these are the different phases that we went through, each phase lasting for about 4 months each, where we set up the expert groups and then actually using the Delphi approach, develop some consensus statements, and then actually develop the guidelines. And I'm happy to present these guidelines to you. We have 2 sets of them. One is for DDH and the other one is for the cerebral palsy hip surveillance. And they're both available on our website for a free download. We are trying to disseminate this information as much as possible to all the various stakeholders and the various associations, and also more recently, trying to liaise with the government. So what's unique about these guidelines? They're relevant to the healthcare system of India. They're broad-based enough to remain applicable to the diversity of India's healthcare settings. The focus on surveillance rather than screening, emphasizing the concept of periodic examinations. And what we try to do here, which is quite unique to our setup, is to actually align it with the national immunization schedule, which is run very efficiently in India, surprisingly, and brings millions of children into these well baby clinics. And we've tried to align those guidelines along with those visits that children come for the vaccinations to see that we can actually capture those children at those time points. Another good feature that we have permitting X-rays to be used to screen for DDH at an earlier age, in the understanding that ultrasounds are not always available, and even if they are, we don't have the expertise at times to interpret those ultrasounds in young babies. We are now in the phase of developing knowledge translation tools, both for the DDH and for the CP hip pathway. So in short, there are some of the lessons that we've learned to involve the relevant stakeholders right from the beginning, identify the potential barriers to building knowledge and awareness, considering the existing healthcare system, and following a feasible, multi-phased, evidence-based and scientific approach to guidelines development. As Kishore always says, it's important that once you've done something, share it around with the others. And what we've done now is to try and help other organizations and other countries to develop similar guidelines. And more recently, we've completed a similar exercise with the group from Sri Lanka. And I'm happy that we're moving forward with that. So thank you very much for your attention.
Thank you, Al. And last up for this section of late breaking abstracts, we have Renee Van Stralen from Erasmus as well. And she is going to be presenting, do adductor tenotomies prevent hip subluxation in children with cerebral palsy? A systematic review.
Hi, my name is Renee Van Stralen, and I would like to thank you for the opportunity to present the results of our systematic review of, on the effect of adductor tenotomies in progressive hip migration on behalf of all my co-authors. We have no relevant disclosures. Up to a third of children with cerebral palsy develop hip migration, and the risk increases with a higher GMFCS. In progressive hip migration in young children, an adductor tenotomy is an accepted treatment option to delay or prevent progressive hip migration. However, several papers have reported results with a high variability. We performed a systematic review to help determine the effectiveness of the soft tissue release in the prevention of progressive hip migration in children with CP. Secondary outcome measures of this systematic review were to determine whether age at surgery, surgical technique, preoperative hip migration percentage, and the duration of follow-up impact the failure rate. Let me see. A thorough search of the literature was performed to identify original articles qualified as level 4 or higher. Our inclusion criteria was skeletally immature patients with CP, and exclusion criteria were papers published in a language different than English, previous proximal femur or pelvic operations, case reports, technical notes, and published abstracts. The Prisma flowchart is illustrated here. Our literature search identified 268 titles, of which 27 met our inclusion criteria and were subsequently selected for analysis. In these papers, the mean age at surgery ranged from 3.4 years to 8.5 years, and the mean follow-up ranged from 12 to 148 months. 17 papers included information on failure rate. There were small differences in the definition of failure, but it was roughly defined as progressive migration or the need for additional bony surgery. The combined data from these studies described the results of 2,070 adductor tenotomies, and a prevalence meta-analysis on these 17 studies was performed. The prevalence meta-analysis showed an overall failure rate of 39% at a follow-up ranging from 12 to 148 months. When looking at our secondary outcome parameters, we can show the following results. When looking at the results of adductor tenotomies performed before the age of 4, the failure rate was only 13%, and when performing adductor tenotomies after the age of 4, the failure rate was 46%. This difference was just not significant. Dividing the population in ambulant or non-ambulant patients, the failure rate in ambulant patients is somewhat lower, but also not significant. Performing a neurectomy of the anterior branch of the obturator nerve has no impact on failure rate. Having a preoperative MP of over 40% showed no difference in failure rate compared to a preoperative MP of under 40%. And there were no differences in failure rates when comparing studies with a shorter follow-up to the studies with a longer follow-up. Only if releasing only adductor longus, the failure rate was significantly higher compared to different surgical techniques. Looking at migration percentages, the mean preoperative MP of the total meta-analysis was 33.4% and 29.9% at follow-up. In the studies describing adductor tenotomies in ambulant children, the mean preoperative MP was 34.9% and 23.2% at follow-up. In the studies describing non-ambulant patients, the mean preoperative MP was 43.8% and 34% at follow-up. Several papers have found that the failure rates after adductor tenotomies are significantly higher in children that are more severely affected. Combining the data from several papers in this meta-analysis, there appears to be some difference in failure rate, but the relationship was not statistically significant. This could be related to data distribution. Another point of discussion is the reported migration percentage. Most papers describe either results by failure rate or by describing migration percentages preoperatively or at follow-up. Our analysis showed a little bit of a discrepancy between these two methods, where pooling the MP at follow-up shows relatively good results. It's possible that the patients undergoing bony reconstructions were excluded from measurements of MP at follow-up, and it's not always mentioned in the methodology appropriately. This is why we feel that failure rate is probably a more reliable way to describe the overall population. In conclusion, in this combined meta-analysis of 17 papers and 2,070 hips, the overall failure rates of adductor tenotomies was 39%. Failure rates are significantly higher when only lengthening adductor longus when compared to more extensive releases, and failure rates are a little bit higher when performing adductor tenotomies after the age of 4. So maybe adductor tenotomies can be considered in younger children in order to postpone secondary surgery, but it might not completely negate the need for additional bony surgery. Thank you for your attention.
Okay, great. Thank you so much. We are running short on time. We have had 4 excellent talks in this late-breaking abstract session, and we'll take a little break now for tea, coffee, stretch your legs or hands a little bit. Feel free to move around and talk to any of the 4 speakers if you have any questions that we have not addressed in this last session. So tea, coffee is right there on the right, on my right-hand side. So thank you, everyone. We'll reconvene in 5 minutes. 15, excellent.
Everyone, we're ready to move on to start the next section of the meeting. Welcome back. Thanks for your attention. And we have next up, we have Dr. Michelle Poldevort, who was an orthopedic fellow at Utrecht, who's been working on a collaborative study with our group at BC Children's, looking at validating the IHDI classification system. And I think she just managed to sneak home in time in the Netherlands from clinic to speak to us today. So Michelle, please take it away and let me know when to advance the slides. So.
Yes, I'm here. Can you all hear me well?
Yep, we can hear you.
I'm neither too loud or too, too silent. Okay, so what I would like to talk to you about today is that we are working on validating the IHDI system for DDH, but we want to validate it for younger children by comparing that to same-day ultrasound images. Oh, yes, next slide, please. I won't bother you too much about the need for good treatment of DDH because I feel that you all know that. I think the golden standard in the diagnosing of DDH very much differs from location to location and also from the age of the child. The gold standard can be considered the ultrasound, and sometimes it's considered an X-ray to measure tonus angles on. Next slide, please. So the IHDI quantifies the severity of displacement, and it uses the center of the metaphysis instead of using the ossific nucleus. And it should be therefore applicable in all ages and also in younger children, and especially in countries where the ultrasound is not readily available. This is very important because it might make good healthcare and diagnosticization of DDH at a young age readily available. Next slide, please. So we have a cohort in Utrecht that compares the ultrasound images to X-rays at the age of 7 months, and we want to add measurements of the IHDI into this. And in order to try to make it applicable for younger children as well, we used Photoshop to remove the epiphysis to see if there's any difference in the measurements that we did in the past. So what we hypothesize is that the IHDI is a good alternative to the classification on ultrasounds, and that it has lower intra and inter-observer variations in accordance to what we have seen on older children in our other cohorts. And we feel that it, since it can be applied in younger children, it can make healthcare more available in developing countries. So actually, what I'm here for today is to ask you for a big favor, and we want to ask you if you want to participate in validating our scores by doing some of the measurements that you also do in clinic. And therefore, we will later send out an email that has an invite to join this study. And it shows a link to a server where there are ultrasound and X-ray images of 25 children with DDH. And it comes along with a very nicely built RedCap survey. So it's that's a form that has entry points for all the data that you measure. And we also put in the link to an online measuring tool so that it's not necessary to bring all the X-rays into your own PAC system, but you can just measure all the angles online. So then we ask you to do measurements, the tonus angle on X-ray, the alpha angle on ultrasounds, and the IHGI classification that you would give these children. And the data can be saved in between measurements. And when they are all done, we ask you to synchronize them so we can analyze these data and hopefully further validate the IHGI score. So just for some clarification, I think you all use these angles on a daily basis, but we are asked to measure the tonus angles, so the red angles on the X-ray and the alpha angles on ultrasound. And it can be done using the same measurement tool. You just flip it around. I made a very easy instructional video about it. So this QR code actually leads to the measuring tool that we have online. It is very useful if you don't have good PACS measurements that are available. So on the left image, you see what it looks like. So you just get a big geometric image in there. You can make it bigger, you can make it smaller. You can zoom into the image because here it's not too clear to see. So I usually zoom in a bit more, and then you can just move the lines up and down and measure your axis. So I actually used it for this study, but after that found it to be very useful, both at work and at home. So if you want to practice with it, you can just use the QR code or wait for our email that will be sent out. So I feel that the video instruction is not working, as I think, Emily, you said.
Yes. Yeah, so we will make this video available. Michelle has done a how to use the tool video that we can make available to anyone interested.
Okay, so again, the steps, it would be very helpful for us if you are willing to perform these measurements and send in some data. If you have little time, it doesn't need to be the complete cohort, but we would, of course, very much appreciate it if you do. So thank you very much in advance, and thank you for the opportunity to speak here.
Thanks, Michelle. Yes, sorry, question.
Hello, Nina Georgievich from UAE. I have one basic question. These two images there, one is for the child 6-7 months, another is for the newborn because the nucleus is very small. So this is not in the same time. It's not possible. So how can we do 6-7 months when the nucleus is already big enough to prevent the lower end of the ileum? Just practical question.
Yes, these stills are just used to illustrate the type of measurements that we do. These are not from our actual database. So the ones from our database are all 7 months. And the ultrasounds, we have just the best images to perform the measurements on, and it's very possible to measure the alpha angle there. It is bigger, but it's still very much possible.
Sorry, maybe I'm a little bit passionate, but the ossification center is the only reason why we cannot perform the ultrasound to the kids. So this ossification center on the left side will prevent the proper ultrasonography. period.
Well, we do these because at 7 months in our hospital, we switch from the younger child having the ultrasounds to the older children having the x-rays, because we feel that that is, for us, the point where it gets harder to compare these two, so that the nucleus is, I agree, bigger than it is in this picture, because this is just something that I took off the internet to show how to measure the alpha angle, but it does look similar. Even though the civic head is bigger, you can still see the labrum and all the graph points that need to be there for a good checklist one.
Great, thanks, Michelle.
Bye.
All right. Al, I think you're up next. Are we going over to? Oh, okay. All right, so I think we're moving into the section on just updating general pillar updates. So for that, we have Salil.
Wonderful, thank you. So I think basically all four pillar, the leads from all four pillars will be just speaking about what's been going on within the pillars. So let me just get up to that. Just to bring everyone up to speed, this organization has been broken up into these four main pillars. So the community pillar, which is more internally looking, focused on some events such as this meeting, figuring out how to build our infrastructure, internal communications within the group, as well as the structure of the network. And then the other pillars, which you can see here for research, professional development, and growth and outreach, will have the leads from each of those pillars speaking towards that as well. So myself and Alric are the leads for the community pillar. These have been our strategic priorities for the last few years to build a functional network structure, which I'm not sure if that's included in these slides, but we're happy to share that organizational chart with you. To organize membership events, set up functioning committee groups, develop and implement strategic plan for Hip Hop Network internal communications. So I think some of you have already volunteered for the committees that have been formed, and we've started to have some of those initial meetings to talk about the specific aims that each of the committees and subcommittees are going to be working on. So we really encourage everyone to get involved and volunteer. I think that's the only way to keep this organization going. The Vancouver group has done an amazing job of building it to where we are at this point. And now that they have all of us together in a room, I think it's important for us to start participating. So the two action committees under the community pillar you can see here are the events and the membership and nominations committee. So the next steps are the annual HIP Legends meeting that's coming up in just a few weeks, and then figuring out how to build an internal structure to keep track of the memberships, as well as figuring out how to communicate within ourselves, I think is our next main steps. So look forward to that. Here's the HIP Legends information if you want to scan that QR code. It is a virtual meeting. This is the third year now that fourth year that we're hosting it. So we look forward for you to submit some nominations for some HIP Legends and participate with us in that upcoming meeting. All right, so Woody and Emily, you want to come up and talk about the research pillar?
I'm not sure if Woody's here yet. I don't think so. He was coming from the EPOSNA board meeting, so I'll speak on behalf of both of us. So he's my wonderful pillar co-lead for the research pillar. And sort of just going through our strategic priorities for this pillar. We mainly want to engage researchers with resource materials and other communications. And to that end, we have put together, as we'll see, establishing a research toolkit. So we have put together a research toolkit that I believe is either soon to be published or published on the Hip Hop Network website, or sort of preliminary round of toolkit items. that are available for a whole range of sort of research experience if you're looking to get started in research for the first time, get involved in global collaborations, writing grants, writing manuscripts, etc. And also, as you've heard today, I speak at the beginning about developing this rare hip conditions registry, which the work is now substantially underway, and is something we look forward to continuing to develop. And so, as I said, we're looking to launch with at least the first two hip conditions that we heard today. We're also looking to establish action committees. So several of you in the room and online have been sort of we're having our research council as well as sort of shared with the professional development group, the grants committee, that we're looking forward to sort of onboarding process and getting the action underway, as Salil said, sort of utilizing the energy and the passion from everybody here to continue and really get this research pillar growing. And as I mentioned, our new research toolkit is available. You can check out some of the initial materials that are there by scanning the QR code. We will be working on continually updating elements that are in that toolkit, as well as we'd love to hear any suggestions if there's any particular materials you think would be helpful for you or your colleagues to add to the toolkit. We'd be more than happy to look at that. And with that, I think, oh yes, I have Ben Shore here to give an update on the professional development pillar.
Hey guys, I drew the short stick with Pablo, thanks. The two of us are part of the professional development pillar. I think the goals for this pillar are to try and help advance the curriculum on a global stage. So we want to create a common area where we can go to get resources for kind of all of the hip conditions, from early learner to attending, essentially, and create almost like a library or a common workplace. That's really the big picture vision. And by creating that registry for trainees, we can help standardize educational resources and kind of elevate the level of education globally. And also, as we develop that, maybe the hope would be to create some mentorship, both formal and informal. And if you think about the way we even have our fellowship opportunities now, by using our network, it would be our hope in the future to almost kind of develop fellowship pipelines across the world between Hip Hope members, and as a way to help improve access to education and to teaching and experiences. And then the final part is just how do we facilitate either internal granting as well as external granting related to education and research. And so are you guys controlling the slides or am I? Oh yeah, this thing. Sorry. Yeah. There we go. Okay. There's too many buttons here. Sorry. So there's a couple different things that we've done. So with respect to the pillar updates, there's the doc matter case discussion. Some of you have participated in that. If you haven't, it's a great place to post cases. The concept being it's a place where we can share our challenging cases and get people's perspectives. I think that sometimes people are not always comfortable sharing challenging cases. And if we can create a network where we feel comfortable sharing cases and sharing ideas and helping each other out, I think that's going to really build the community. Establishing action committees, both with education and grants, like we talked about. And then, you know, the Hip Hope Network posted, I think it was in the fall, the SMA webinar with Jason and Evelyn. It was awesome. And so if you haven't heard it, I'd encourage you to hit the QR code, and it's recorded so you could watch it at another point. But I remember I was participating and listening in an airport. I was in the Boston airport waiting to catch my flight and hoping that my flight got delayed so I could finish hearing the rest of the webinar. So it was really great. And I think, you know, that is the SMA topic is really one like little snippet of where the opportunities for us exist. Like that is an area, there aren't that many areas in orthopedics where treatment has changed and the paradigm has shifted so significantly in such a short period of time. And so the opportunity for interventions for us is, you know, expansive, and it's a relatively rare condition. So the only way we're going to quickly figure stuff out is in a large group like this. So it's just super exciting. So that's the kind of professional pillar stuff. Growth and outreach. I don't think Pranay's here. Joel's going to step in. I must say, for those of you who have done Zoom, Joel looks a lot taller in real life than he does on the Zoom camera most of the time. So
we have to make the camera up here. Yeah. Thank you. I am speaking on behalf of Pranay, Mr. Pranay Budev and Dr. Patricia Moreno from Brazil. So Pranay is from the UK. They have been amazing support for the growth and outreach pillar, which is really focused, you know, if the community one is internal and membership engagement, it's external and drawing attention and connections that we can work with that are like-minded groups and people with the Hip Hope Network. So Pranay, I'm not sure if I know he's been online. He's not able to join in.
I'm here, Joel.
Oh, if you want, you can take it away and I'll step back.
Well, thanks a lot, Joel, for stepping in. And sorry, I can't be there with you guys. I'm currently heading to all of you, or I should hopefully be there by the end of the session for the GHDR session. But as one of the pillar leads, along with Dr. Marina from Brazil, we're in charge of sort of growth and outreach, as Joel said, is the external communication and really helping drive awareness of the Hip Hop Network across all different platforms, and really trying to get Kishore's and Emily's vision of local to global. And I just sent a message on our group to everyone there to say it's so amazing to hear representation from all around the world that's in the room right now. You've got people from the US, from Europe, from Australia, from the Emirates, from Africa, from South America. You can hear it all. So we're obviously doing something right and want you all to share this network and the opportunities within this network to your colleagues from not only your own institutions, but from around the world. Obviously, our priorities are to raise awareness of this, but also to create partnerships, not only with other hip conditions like the GHDR or the IPSG, but also with international and national societies. So once again, if you have a role sitting on one of your national societies, please let them be aware. And we have a bunch of emails and mandates that we can send you all to help raise awareness of the Hip Hop Network. Finally, Kishore probably does the lion's share worth of work of this, along with the team in Vancouver, but developing fundraising strategies and sort of an action plan to see how we can raise money to help identify conditions like discussed today, SMA and Down syndrome, which we're pooling our sort of, our sort of collective patient groups will really help us drive forward, future results. So, as mentioned before, we have our Hip Health Day on the 2nd of June of this year. It's a Sunday, it's held virtually, and we use this to not only honor a few of our own legends that we have within our field, but also highlight some of the work done by advocacy groups and those involved with other elements such as physiotherapists. So I highly recommend to join that. It's always incredible to learn from each other. With regards to the action committees, we're hopefully going to have a session on this a bit later that I'm sure Joel will lead. But we're looking to get members to join 2 committees in particular to growth and outreach, one for media and communications to help us drive our sort of social media channels and how best to communicate with not only our members, but those who are not yet members, future members, and also secondly, those advocacy and funding. So please join Joel later in one of the tables to discuss that. Excited today to say that we're now live on LinkedIn. So please join us on LinkedIn. Again, share it, raise awareness of this, and I'm hoping you'll see in the room the sort of network that you have already developed just sitting there, meeting people from all around the world. This has a huge power to really help drive pediatric hip health moving forward. So that's it for me. I hope to see you all a bit later. Thanks a lot, John.
Thank you, Pranay. Kishore?
Hey, Pranay, can you come back on camera or you're on? Okay, let's bring Pranay back up. It's his birthday today, so let's sing happy birthday for Pranay. Happy birthday to you. Happy birthday to you. Happy birthday, dear Pranay. Happy birthday to you. Hey.
For a recording as well. Thanks, Kish.
Another person that needs a special recognition for all of this, and how many of you have heard me talk about dolphins? Can you raise your hand? Anyone that knows me knows about me talking about dolphins? And the guy that's standing at the corner there, Peter Wilkin, is the dolphin guy. Peter actually, some of you may recognize, actually did the strategic planning for Hip Hop Network, and he's actually the man behind bringing this vision and a lot of what you see together. He's also helped us with branding for I'm a Hippie, for our Hippie Lab, for many others. Peter won Oscar equivalent awards in the branding agency over the years. So he's a legend in terms of brand and strat planning and whatever. He's going to be here for the conference with the Hippie booth. So please feel free to say hello, talk to him. He's a legend of a man in terms of his creativity and really giving direction. So thanks, Peter, for being here. Hello. Yeah, can we get everybody seated, please? So we have a packed agenda for another hour. Thanks for staying on time and your active participation. We packed a lot on this agenda, and thank you all for cooperating with it. Okay, so if you're wondering what are we going to do with all of your valuable feedback and suggestions that we got, we're going to compile all of that. Our leads that were at your tables are going to go and get all of that together, and they're going to communicate that back with you when we send out a meeting summary. We will take all these posted notes and the nice feedback that we got from you, and we're going to communicate that back with you in some capacity. I just want to gauge your interest. So one of the things that we've been talking for a number of years, and Harry Kim is just going to walk through this door right now. And Harry's been asking for a few years and saying, you know, what is the aim of this network and how is this going to improve hip health of children from around the world? So if you could just go on this Slido, scan. And this is really, really important to gauge your interest. And I think we really appreciate any feedback that you can give. And I think our next steps will depend on this. Just to give you the kind of work that's being done in the background. So it's largely led by a lot of volunteer time from all of you, several of you over the years. A majority of the resources for this are provided by a family called a Peterson family in Vancouver that made a large donation towards this, as well as I'm a Hippie Foundation. Without them, we won't be doing it. Just the cost of this afternoon for us to do what we're doing is $54,000. So we won't be able to do any of what we're doing if not for the incredible support that we have right now from our very generous donors. But we really need to decide what the next steps are, because we cannot continue to do this without some engagement and involvement from all of you, going that there is an interest, and second, and what the next steps are. And each of you, if you care about hip health of children, really taking a volunteer effort to be involved and moving this forward. If it's just left to the team in BC and few dedicated volunteers, it's not going anywhere. So I think it's really important that we have your involvement and your feedback. Okay, do we want to go to the question? Okay, I'm assuming, I think there's more than 29 people here. So if you could log in to Slido if you're able to, but otherwise, if you're not connected to Wi-Fi, you're not able to do that. We understand that. So we have roughly about over 80% of you that would potentially attend a meeting if we were to do an in-person meeting again. Great. Okay, so looks like either September 2025 or April 2026, depending on where we are, and we'll make sure they don't interfere with major orthopedic conferences, and we'll send out some dates, and we'll see again what people will come back with. And the intent is not to host it every year in Vancouver. The intent is we do one in-person meeting every other year in different parts of the world, and every other year will be a virtual congress, and we'll still have this meeting. We'll have lots of papers that are presented but recorded ahead of time, and discussion is done live via Zoom. So that's the intent. And then we'll combine all of that together and we'll send it. So we'll send you the format for a virtual meeting, but the next in-person meeting would be in those. Okay, looks like half of you would be interested in submitting an abstract or a case discussion. I'm not seeing any unlikelies, but lots of maybes, and we'll see what does it take to convert the maybes into yes. Okay, great. Yes. The goal of the meeting is I don't think we have a focused pediatric hip meeting, just like the way they have for LLRS or they have for cerebral palsy or for spine. And there are several things in pediatric hip that we need to really address. So for example, shape modeling, engineering, ultrasound. We were just talking about, we're doing a big validation study, but we don't bring and we don't hear. Most of these meetings, whether you go to EPOS or, EPOSNA, those sessions are packed, and at maximum, you have 1 or 2 sessions and no more than that. So I think we really want to bring the interest groups and people that are doing pediatric hip, it doesn't matter what aspect of pediatric hip, really bring them all under one umbrella. So hopefully we can come up with themes and areas where we need to address, just like PRISM does. And I don't think it devalues any other meeting. It only enhances the meeting. And I think our content here at EPOSNA of all of these subgroups that there are, our specialty focused meetings, will only enhance, I think, what's being presented here, because we are not scratching the surface in terms of learning from each other. Today, there are 3 presentations I've heard in the morning that I want to follow up with the investigations and see how we can collaborate. And that's basically what we're looking at. And also what we hear is a very North American perspective, or what we hear is a very European perspective. And we're hoping with every other year we do virtually, even the people that are not able to travel, we're able to bring those in to be able to present and learn from them. So that's really the objective. Any other questions on those 3 questions, or do you have any thoughts, or what can be done differently? What can be done better? So maybe Colin, if I could get you and Tony have a lot of wisdom. So maybe any thoughts that you can share about, what you've seen today and where this could go.
I would be concerned that our society in general is moving away from in-person meetings and towards remote learning, which means I think that if you're going to hold a single issue meeting, people must see it as very attractive and must see it as providing something that they can't get any other way, or you won't get people to attend. And that, I think, is becoming more and more difficult each year that passes.
Tony, do you have any thoughts?
Well, I think I kind of asked this question a while ago in our subgroup. What is our overall goal? It gets bound up in how do we organize, but what is our hope for accomplishment?
Yeah, I think it's to improve hip health and mobility as quickly as we can. I mean, some of the things, we've been treating hip dysplasia for for, I don't know, a lot of years. And we're now talking about classification system, what's the best way to screen, and what are the things to do. And we got lots of opportunity now with technology, and we've got Manoj sitting here, and we have a lot of AI stuff. We have a lot of data now between different databases, but we're looking at all very piecemeal. We're looking as there's an anchor group, which is very focused on adults and hip, but it's a continuum of learning, and there's a hip is a hip that may have different diseases, but shape, if you think about impingement as a micro or macro impingement, imaging, and they're all large concepts in hips that you need to bring congruence. And I think that's the hope with this network or with this group, is to be able to do that. Manoj.
So I was just gonna, so not being devil's advocate at all, but what happened in Europe with EFORT, which was the combined society for all the subspecialties? They started seeing less and less people attending their annual meetings as people split off into EPOS, the European Hip Society, etc. Same thing sort of happened with AAOS here as everyone splits off. And I know there's been, I mean, I've been privy to some conversations at EPOSNA that they're worried that the more of these society, little societies are set up, the less attendance. Is that a worry, or?
I think
we worry about it on the other side of the pond.
So I've heard that a lot, but all the people that expressed worries have all been presidents of dual societies. They've been president of SRS and POSNA. They've been presidents of PRISM and POSNA. They've been president of LLRS and POSNA. They've been president of AACP and POSNA. So if those conditions require a specialized effort, tell me why not pediatric hip? That's honestly, that's simply my argument, is why not those of us that predominantly do pediatric hip can come and meet together, only interested. I mean, nobody's forcing anyone. If you're interested in being a part of a group, why are we not doing that?
Keish, can I follow up on Manoj's comment? We do have to be mindful of the amount of finances that people have, the CME time they have, and those sorts of things as well, as far as thinking about frequency of the meeting, tying it to another meeting that gives people the most bang for the buck. Like with EPOSNA, this is a perfect opportunity right now, what you've done. And I think a lot of people are here from all around the world in person because of that. So when brainstorming about how to make a separate Congress, I think need to keep those things in mind, or else what might happen the other way is that we don't siphon them off from the big meetings, but this meeting fails to take flight.
I think great point. I mean, some could be that we do 1 year on the sidelines of POSI. So we have a lot of members from there that do it, and you have a meeting and people that are in the Southeast Asia are able to attend, right? Not everybody. And we do on the sidelines of EPOS 1 year so that people that are in Europe that can attend. So there are ways I think we can look at this, or with APOA, which is Asia Pacific Orthopedic Association. We can combine efforts with them and do that. So those people and they're attending that meeting could probably come just like the way this meeting is.
That's what came up at our table, actually, when we were just talking about those aspects with Tamara, was, about surveying the group and say, well, what meetings are important to you? What ones do you make a priority for? If it's APOA for a lot of our members, for example, rather than, we should acknowledge not just POSNA, EPOS, but also the global community, POSI, all these different things, and can have it move around that way. That might be another way to do it, with every now and again having a standalone big Congress meeting where it all comes together.
Fantastic. Any other thoughts before we move on, or we're here for the rest of the meeting? And I'd love to hear your, as Manoj put it, devil's advocate views, because that's, I think, really important for us to hear diversity of thought in terms of, how we're going to move this forward. Jay?
Sure. Sorry. 10 years from now, how would you know you'll be successful through this project? And what would you be disappointed if you only achieved in 10 years?
I don't use the word success. I use significance. What would significance look like is that just like the way we had today, we're learning from broader representation of people about pediatric hip issues. And there's a lot of work that's being done around the world. And with everybody's combined wisdom and the knowledge, whatever they're generating, that we're able to improve hip health in our local settings, whether it's in Chicago or Vancouver or BC, but together globally, we're improving hip health of children. That's something I don't think I'd put, I think a lot of you that have read the book, The Infinite Game. So I use anything that we do as the infinite strategy, which is I'm taking a leaf out from orthopediatrics. Dave Bailey talks a lot about this. A finite game is where you have a fixed endpoint, and we have successes that are measured by number of publications, number of people attending, and whatever. Infinite game is we have a cost, which is if every single one of us here commit to improving hip health of children your own way. You know, I've heard today Courtney talk about therapy, you know, and IPS chief, she takes a lead on coming up with guidelines, working with other people. We've got people in Europe that are working on it. So why are we working in silo? If we combine those efforts, and if that leads to an improvement in care for children with hip problems, that's the significance that we're all going to create collectively. And there is no time frame and there is no end date for this. We're all in the business. If you're in healthcare, you're in the business of contributing the best you can, and somebody takes the baton and takes it forward. Harry?
So yeah, Kish, thanks for the opportunity to talk. So I feel the primary question that I have is for my patients. How do I become the best surgeon, best researcher, and best advocate for my patients? And when I think about that, it's not about how well the EPOSNA is going to do or how well certain society is going to do. How best do I learn about new techniques as well as what is being done elsewhere? How do I engage with my colleagues in terms of education as well as promoting the academic excellence? How do I best do my research? And if you think about that, and if you are engaged in pediatric hip research, it is vital to have pediatric hip society. I really don't like the term Congress, and it should be Pediatric Hip Society because that's what the focus is. And this is coming from the surgeon's point of view, so I don't represent everybody else's thought, but I think that's important to do. And I don't think it's going to take away from EPOSNA. I've been coming to EPOSNA ever since I was a resident or fellow, and I don't see myself not attending. And there are great examples. Scoliosis Research Society, where some of my partners at Scottish Rite, they attend SRS, and they come to EPOSNA.
Yeah, I honestly, that argument though.
And that, can I just make it one?
Yeah.
So I am also so I have a pretty busy schedule, a lot of meetings, research, and so on. But I am completely for in-person meeting because that is so much more engaging, and it's better for sort of action as well as developing new ideas.
Yeah, I think, Harry, it doesn't require 100 people to attend. If there are 30 people that are committed that do pediatric hip that are interested, that's what's going to start with. I also don't buy into that argument. I've heard that, well, this is being discussed at a board level, and they're not supportive. I mean, here, we're not, all the people here are just now EPOSNA members. We've got POSI president here. We've got people from South America. We've got people from Africa. So this is for combining hip health advocates all together, whatever way it's going to morph into. Sorry.
I said it in one of the breakout sessions, but I think that this piggybacking on existing meetings is very good because it saves a lot of us money and travel. Yeah. But I think that it should be expanded to other areas. You say that people are coming here, but the people who are coming here are the people who are more academic or researching or lucky to have higher incomes, and the people who are taking care of a lot of the patients in Asia and Africa, in many other remote areas cannot come. So you can either give scholarships for them to come, or you can take the circus out of town and go there. And I think that this should be considered.
Yeah, we'll definitely do that. And that's why we said maybe every other year is actually a virtual session that we do. So that way people that can't travel also have an opportunity to engage and present. So thank you. And more to come on this. So stay engaged. And I'll hand it back to, I think, Emily.
All right. And moving on to the second portion. Oop. Our slide advancers may be out of batteries. Not sure. Slide advancer is not advancing. But we're moving on to the second portion of our late breaking abstracts. Seems to be going now. Thanks, Tamara. All right, so first up in this session, we have Dr. Dave Moore from Children's Health Ireland in Dublin. And he's going to be presenting a 7-year experience of day case pelvic osteotomy for developmental dysplasia of the hip.
Good afternoon. Can everyone hear me? Can I just check?
Great. Yes, I think we can hear you. Just let me know when to advance the slide.
I will do. Thank you. So firstly, thank you very much for giving me the experience or the opportunity to present our research entitled The 7-Year Experience of Day Case Pelvic Osteotomy for Developmental Dysplasia of the Hip. So next slide, please. Okay, yeah, thank you. So around the world, outpatient operative activity is becoming more widespread. In Ireland, DDH has an incidence of just under 7 per 1,000 live births. It leads to a significant number of referrals to orthopedic services annually. And this high demand has encouraged the drive to optimize efficiencies of service provision in a pediatric orthopedic setting. So to date, our pilot study describing the benefit of performing osteotomies as day case procedures in a pediatric population is the only publication of its kind so far in the literature. And here we describe our longer term experience with this novel day case pelvic osteotomy initiative at an urban tertiary national referral center. And we also describe any potential complications one can expect when performing day case osteotomies. Next slide, please. So this was a non-randomized prospective cohort study conducted to compare conventional inpatient pelvic osteotomies with a day case osteotomy performed over a 7-year period. It took place at CHI or Children's Health Ireland, Crumlin in Dublin. And here's the inclusion and exclusion criteria at the bottom of the page. And the decision to treat DDH operatively is based on a raised acetabular index. Salter's and Pemberton's osteotomies were performed using well-described and standard surgical techniques. And information was collected prospectively by DDH clinical nurse specialists and recorded in our local DDH database. And the primary parameters assessed included clinical and radiographic outcomes, and the financial implications of this novel process and the reduction in inpatient resources were included in the secondary outcomes of the study. And for all cases included in the day case group, a strict protocol involving anesthetic, surgical, and nursing staff was implemented from the time of admission through to discharge as follows. Next slide, please. So all parents of patients eligible to undergo day case surgery were informed of the need to assess pain and administer regular analgesia at home postoperatively. A leaflet with all relevant information was provided to parents along with a prescription for oral morphine to ensure they had necessary analgesia on discharge. Note this leaflet on the right of your page has since been updated. We no longer use this one. Analgesia consisting of or diclofenac or diphenine, dexamethasone and clonidine were also administered intraoperatively. And all patients had a single shot caudal epidural or fascia iliaca block with magnesium sulfate as an additive. All patients were placed in a hip abduction orthosis directly after their osteotomy. And on the first postoperative day, all parents received a phone call from the DDH clinical nurse specialist to ensure there were no parental concerns. And all patients had follow-up clinic visits at 6 weeks. Next slide, please. So standardized postoperative analgesics were used in all cases. And this leaflet on the right was the original one, as I mentioned, but we've since adapted with updated dosages and times for medications to be given. So regular paracetamol or acetaminophen and ibuprofen were prescribed for 48 hours with oral morphine every 6 hours as required. Next slide, please. So in order to understand what we were doing, we used the HSE annual report and financial statements from 2022. So using this, we extrapolated the total discharge cost for patients undergoing an inpatient osteotomy, which amounts to just over €6,600 per patient. In contrast, the total discharge of performing procedures, the day case, is just over $2,600 per patient. Next slide. So in total, 164 Salters and Pemberton's osteotomies met inclusion criteria over the 7-year period. Of these, 115 hips were day cases. The remaining 49 patients were treated as inpatients with a length of stay of 2 days. So 5 patients in the day case group were kept in overnight following surgery and subsequently removed from the day case cohort. So of this 5, 3 were for pain control or parental concern, and 2 were kept in just because of vomiting. Taking these into account, there was a total reduction of 220 inpatient bed days reported over the 83-month period. Clinical and radiographic outcomes were the same in both groups at final follow-up. And for 110 day case patients, the total cost to treat amounted to €293,700. So calculating the difference, there was a total saving of around €434,390 made by the hospital for the 110 day cases performed. So this amounted to just under €4,000 saved for every day case. Next slide, please. So in terms of complications, 22 patients had unscheduled representation to either the emergency department or to the outpatient department following a phone call with the DDH clinical nurse specialist. 5 of these patients were kept in overnight, purely for analgesia optimization, and they were discharged without event the next day. And the total cost of an emergency department attendance and overnight admission was just over €1,200. So therefore, adjusting for the 5 readmissions in the day case group, the overall saving to our institution with the introduction of this day case model was €428,150. So the other 88 day case patients reported adequate pain control with no concerns warranting reattendance. And 8 patients that reattended had superficial wound infections or wound-oos, but all were discharged from the emergency department with antibiotics and were fine at final follow-up. And there was no recorded cases of hardware failure, osteotomy displacement, or reoperation in the day case cohort. Next slide. So in 2020, as I mentioned, we originally described the first application of this day case pediatric osteotomy initiative in the literature. Over a longer period of time, with more experience, we've continued to show that day case surgery is equally safe. It's radiographically equal and financially preferable to the traditional inpatient model of care. Day case surgical procedures have been introduced with notable success in other areas, such as trauma or adult knee or hip or shoulder arthroplasty. There are numerous factors to consider in order to succeed in establishing an outpatient program, including the presence of a clinical nurse specialist, careful patient selection, along with the help of our anesthetic colleagues, as well as preoperative patient education and specialized protocols. Proper patient selection and education and a well-defined clinical pathway are all key for success. And we acknowledge the importance of the multidisciplinary approach to the safe introduction of an initiative such as this, as well as a rigid inclusion and exclusion criteria. Next slide, please. So a review at 7 years has shown that day case pelvic osteotomy surgery for DDH remains safe and cost effective, and it significantly reduces the demand on inpatient hospital bed resources. Savings of just under $4,000 per day case have significant future financial implications for all treating institutions. And this novel outpatient model of care remains a clinically equivocal alternative to the traditional inpatient model of care for DDH osteotomies. Next slide, please. Thank you very much.
Great. Thank you very much, Dave, for the presentation. And moving along, next up, we have Al again. This time he is going to be presenting on utilization of AI-assisted cinesweeps, ultrasound for screening of DDH in infants. Wait, Al.
Thanks, Emily. So moving on to something exciting, I think artificial intelligence, deep learning is what everyone is talking about nowadays. And this is a research project that we've been working with the University of Alberta. And I'd like to thank Sukhdeep for introducing us to her team at the University of Alberta, especially Jacob Jaremko, who's developed this app, which is called the Meadow app. I'll talk a little bit about this in the pilot study that we have been using this app and a CineSweep ultrasound to screen children with DDH. I've already spoken to you a little earlier about how we've developed now a care pathway and screening guidelines for DDH in India. And an integral part, obviously, of that is the ultrasound. We know that it has quite a few of pitfalls. It's quite operator dependent, and especially in our country, we have a number of radiologists and sonologists who are not very comfortable or trained in performing the neonatal hip ultrasound and then interpreting them. We know that even a small deviation from graph standard plane can lead to several false positive and false negative diagnoses. And this wonderful study showed here that even moving the probe a little bit and angling it in the wrong direction can result in a change in the alpha angle by almost 10 degrees. We also know how artificial intelligence works. It takes basically multiple images. It's trained over a period of time. And by using this training from human experts, it's then able to select the best image in the sweep and then give you some results, even in terms of selecting the correct plane, as well as measuring those angles that we need to measure. So the aims of this pilot study is to determine whether this AI analysis of CineSweep video hip ultrasound is feasible to implement in our country to improve the early detection. And some of the objectives were to look at the diagnostic accuracy, to compare it with the learning curve of this AI tool, to look at the usability by the end user, which is the sonologist, and also to look at parents' acceptance of the screening program, which involves AI. So we had multiple primary and secondary outcomes we're looking at. So basically, as I said, from our screening program, we're targeting children who come to the Well Baby clinics for immunization, and especially at 6 and 10 weeks. We also included children who attend the orthopedic clinic, who are referred by pediatricians, and those from the high-risk outpatient as well, or NICU graduates. And all of these children underwent the conventional ultrasound by the sonologist and then the AI-assisted analysis. If the hips turned out to be normal, they followed up in routine hip surveillance. The ones which were abnormal then had a follow-up scan at 10 to 14 weeks, 4 weeks later. If they were normal, they entered back into routine hip surveillance. If they were abnormal, they went on to treatment. So the technique of the sweep is very simple. All you need to do is take a cine video using your probe going from anterior to posterior. And what the app then does is to identify the standard plane and then to make the measurements on the app itself. So to just give you an example, this can be in the form of an app, or you could even go online and open it through Chrome or any other internet browser. And you can see that within a matter of seconds, when you feed in the video, it will identify the standard plane that's the best fit that it found from the sweep. And then it goes on to measure the alpha or the beta angles and the percentage coverage of the femoral head as well. And right away, if you get a suboptimal scan, if the AI finds that the video sweep wasn't adequate or the standard plane could not be identified, it will immediately spit that information out to you so that you can repeat the scan right there itself. So what we calculated in this pilot study is the proportion of scans which were adequate for AI analysis, and compared that with the ones at human expert review in terms of what's the diagnostic accuracy, and we were targeting at least 95% scan adequacy. We were looking at the cost estimates in terms of what extra resources are required. We also looked at what's the proportion of patients who proceed with follow-up and recommended by the AI scan. And then we also looked at some stakeholder feedback and satisfaction surveys using the system usability scale and a parental satisfaction survey. We are planning to recruit over 1,200 patients in this study. So far, we are just about a third of the way through. We've scanned about 614 hips, and you can see we have all the various graph types as identified by the AI. That's the average age, and that's the sex breakup of the children whom we have recruited. When we looked at the scan adequacy, we found that our target was 95%. We found that almost 95.6% of the hips that we scanned were pretty accurate and adequate for the analysis, and compares very favorably with the human expert review. In terms of costs involved, there were no significant increased costs or expenses due to utilization of the existing resources. Of course, we haven't factored in the cost of the app itself when it actually goes commercial, and then how much would they charge for actually providing us the app and for downloading that app onto your mobile or laptop or tablet. In terms of the timestamp, we found that it's far quicker to do a sweep. It took an average about 89 seconds for the cine sweep, and then to feed it into the app for it to read out compared to the traditional scan, which took almost double that amount of time, and this was statistically significant. In looking in terms of the parental satisfaction, in terms of the amount of wait time and the process itself, we found it averaged pretty high on the parental satisfaction survey. And looking at the stakeholder feedback from the sonologists who are actually doing this cine sweep, again, scored high, more than 80%. And this is a validated question that we use, which is called the system usability scale. So there have been several reports to come out, especially from this group in Alberta, but also from elsewhere, which have shown the value of artificial intelligence and deep learning in developing these AI-based apps, which help us to identify the standard plane and to measure the various angles. And the advantages we feel of this pilot study is that the sonologist can be trained quite quickly. You don't have to be really an expert in doing hip ultrasounds. Even a novice can pick this up quite quickly, because all you need to learn is the technique of the cine sweep and how to feed it into the software, and the image and the measurements are made entirely by the app. We found that it's a really short learning curve. You need a training of about an hour or so by a PowerPoint presentation. And we definitely feel there's a decrease in the false negative scans and with improved diagnostic accuracy. Limitations, of course, as I've shown you, is a single center study so far. All scans were performed by an experienced sonologist, but there have been reports from the same group which have shown that even novice sonologists can do the same training and report the same results with the same degree of accuracy as an expert. So I feel that this is really the future. AI-based technology has, as you know, revolutionized the field of medical diagnostics. And our pilot study, though it's in the initial phase, it's demonstrated the feasibility of using this app and the cine sweep video images in terms of diagnostic accuracy, end user feedback, time, and cost, and has the potential to train even novices, which is going to be a big thing in India, because we don't have so many trained sonologists in doing the graph method. And I definitely feel that over time we can train the AI better and better to improve its accuracy compared to what it already is. And I'm sure this will give a huge impetus to screening program that we have developed in India and for other developing countries as well. Thank you very much.
Thank you, Al. Next up, we have Dr. Sukhdeep Delai from Stollery Children's Hospital and the University of Alberta. And she's going to be presenting today a qualitative assessment of AI-enhanced hip dysplasia screening in rural clinical settings.
Thank you. It's my pleasure to present this work on behalf of our research group. And in particular, I'd like to acknowledge Steele McDonald, who is one of our graduate students and is the primary author of this particular work. A second, sorry. Okay, these are our disclosures. The University of Alberta acknowledges that we're located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, and Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. As we all know, the incidence of DDH in the general population is approximately 1 to 2%. However, it has been reported to be as high as 6 to 30 times more common in the North American Indigenous populations. Infant hip ultrasound is considered to be the gold standard for early diagnosis of DDH. But in most parts of the world, it is only offered to patients who have known risk factors and is usually only available in urban centers where there is existing technical expertise for it. As a result, many populations who would likely benefit the most from DDH screening with ultrasound have the most difficulty accessing it. Oh, this isn't forwarding. Okay, there we go. This is illustrated here, comparing the locations of primarily Indigenous communities in Canada, as you can see with the green and white dots, and comparing this to the approximate locations of existing healthcare facilities with technical expertise in infant hip ultrasound. For those of you who aren't familiar with Canadian geography, these are humongous distances. However, a practical and reliable portable ultrasound DDH screening tool is available, which facilitates accurate data acquisition and interprets images by artificial intelligence in real time. Implementation of this tool in rural communities could make DDH population screening more feasible. The objective of this study was to qualitatively assess the implementation of this tool for universal DDH screening in rural and Indigenous communities across the province of Alberta. 8 centers across Alberta were engaged, and local staff underwent basic training to ensure proper use of the diagnostic tool. To date, a total of 1,141 babies have participated in this study. As expected, the vast majority of scans were found to be normal. 15 confirmed cases of DDH have been detected, approximating an incidence in the 1 to 2% ballpark. However, notably, there have been more than half the cases have had no known risk factors for DDH. And as such, we would expect them to have been missed in the community without this particular screening program. Implementation was evaluated using the Consolidated Framework for Implementation Research, which is designed specifically for healthcare implementation projects. In this study, this construct was used to collect and report the experience and reflections of clinical and research staff involved in the project. The screening tool itself was perceived to be cost-effective if you compare it to the cost of traditional ultrasound, global cost of traditional ultrasound, including the cumulative costs of missed cases in the community. The tool was not only portable, but it permitted the inclusion of novice users, which makes it more adaptable to rural communities than traditional ultrasound. However, there were some issues with internet connectivity that were identified, which prompted alternate solutions which prompted alternate solutions and new innovations to overcome that problem. A key theme that emerged was was to ensure that the engagement with Indigenous communities was guided by a commitment to their ownership, control, access, and possession of their clinical and research data. And we did this via crafting co-developed and tailored agreements with each site. Each site was identified to have unique and different needs and wants that needed to be addressed. These related to things such as schedules and staffing and decisions about when to best perform screening in the existing workflow patterns. Key stakeholders included administrative leaders, managers, physicians, nurses, and community members. More frequent on-floor connection with clinical staff was identified as a factor that improved awareness and led to more frequent invitation to participate in the study. A need was identified to establish local project leads, though, to facilitate monitoring and implementation within a specific catchment area and to act as a local resource for communities. With regards to the timing and pattern of implementation, assessment of local community priorities and determination of how that can affect implementation was deemed important. Sustainability was dependent on 3 things: local networks and supports, including ongoing commitment to providing technical support and encouraging user feedback, educating participants, staff at the clinical site, and community members so that they had a clear perception of the benefits of participation, and a streamlined approach for referral and management of cases that were identified. With regards to limitations, this study was conducted at selected sites where engagement was established. While the conclusions have surface validity, there could be unique factors that might arise in other communities. We lack a clear understanding of the true incidence of DDH in these communities, so the sensitivity of the tool is difficult to establish, but it appears to be better than their current standard of care. And finally, the opinions and views were only collected from participants via secondhand reports from clinical staff and researchers. And so that's an important consideration that needs to be explored further in future studies. In conclusion, implementing a clinical tool requires recognition of cultural context, support, and ongoing evaluation, especially emphasized in rural and Indigenous communities. This tool could allow even the most remote communities to access early care for DDH, preventing long-term arthritis and disability. On behalf of our entire research team, thank you for your time and the opportunity to share our work with you today.
Thank you, Sukhdeep. And for our final two presentations, we have two presenters joining us from Brisbane very early in the morning. So thank you to them. So first up, we have Dr. Shefta Huda presenting on baseline radiographic, physical, and demographic characteristics of children of Maori and Pacific Islander children with SCIFI, findings from a multi-center international prospective registry. Just let me know, Dr. Huda, when to progress your slides.
Good morning. Can I be heard?
Yeah, we can hear you. Thanks.
Perfect. Good morning from Queensland. Thank you for having me. This talk looks at the baseline characteristics of patients presenting with a slipped upper femoral epiphysis from an at-risk group with a large population in Queensland, Australia, namely those from a Maori and Pacific Island background. I have no declarations of interest to make. Maori Pacific Islanders are people who self-identify as an Indigenous person of New Zealand and/or an inhabitant of or diaspora of three major subregions of Oceania. There is a known increased incidence of some pediatric orthopedic conditions in this group, including SCIFI. Reasons for this are likely multifactorial and may be related to genetics, BMI, sporting preferences, amongst many others. There is additionally an increased risk of chronic disease in this population, including obesity, diabetes, and cardiovascular disease, which has been the subject of several government-led public health campaigns in Queensland. Access to healthcare may also be a barrier to improving this, along with various social and cultural factors. Maori and Pacific Islander people first migrated to Australia from the island groups of New Zealand, Micronesia, Melanesia, and Polynesia. This is a very large geographical area in the Pacific, as you can see. However, this study focuses on the diaspora here in Australia, and our patients are Australian citizens. So the clinical question for this study is, do Maori Pacific Islander patients treated for SCIFI at the Queensland Children's Hospital differ in their baseline characteristics compared with the non-MPI population? The location is the Queensland Children's Hospital, which is a central tertiary paediatric hospital in Brisbane, Australia. And we extracted data from a multi-center international prospective clinical registry, i.e. the SLIP registry, and conducted a comparative statistical analysis between the MPI and non-MPI groups. To date, our Queensland Children's Hospital registry includes 136 patients with SCIFI, of which 121 had their index procedure at our centre. 45 of those patients are from an MPI background. This makes up 37% of the entire cohort and is a gross overrepresentation of this population with this pathology. Our results demonstrated that at baseline, MPI patients presented significantly younger and with a higher BMI. There weren't any significant differences in terms of sex or time to diagnosis in our data. In terms of SLIP characteristics, 58% of MPI patients identified a traumatic event precipitating their symptoms, which was significantly higher than those of non-MPI ethnicity. There were a higher proportion of MPI patients presenting with an unstable SLIP, although this didn't reach statistical significance in our univariate analysis. Additionally, MPI patients were more likely to present with an acute on chronic SLIP and a chronic SLIP than acute symptoms alone, although this didn't reach statistical significance either in our comparative analysis, but this may be clinically significant. Interestingly, MPI patients actually presented with a lower percentage slip radiographically compared to non-MPI patients. And whether this is related to the chronicity of symptoms is yet to be investigated. In conclusion, the MPI cohort is grossly overrepresented in our data, with the presentation being 37% of all SCIFI patients coming to the QCH, despite only representing 3% of the total Queensland population. Significant differences in baseline characteristics include presenting younger with a higher BMI and being more likely to have a traumatic precipitant and having a lesser percent slip at presentation than the non-MPI population. There is still a large amount of data that needs to be collected through our registry, and our future plans involve running a multivariate analysis. I should point out that this study does not include the Australian Indigenous patients, which include Australian Aboriginal and Torres Strait Islanders. And although this has also been identified as an at-risk group that is also overrepresented in our SCIFI population at this centre, this is largely at this stage due to issues related with obtaining research consent and recruitment for these patients. Our future goals are to be involved in a multi-centre collaboration with hospitals in New Zealand and Oceania, where there are large proportions of MPI groups presenting with this pathology, and to investigate further characteristics of this cohort, including complications such as AVN, the frequency of prophylactic pinning, or when this isn't done, if this progresses to a contralateral SCIFI, the odds of sustaining a bilateral slip, secondary procedures that are undertaken, including total hip replacement, patient-reported outcomes in the longer term, and then the strain on their hospital system, including length of stay, etc. With this information, the aims are to increase public health awareness and create public health campaigns such as those that are already in place for other chronic diseases in this population in our state. Many thanks to my co-researchers, Dr. David Bade, Kylie Bradford, who's our research coordinator at our centre, and Dr. Chris Carter, the Director of Paediatric Orthopaedic Research, and Ryan Zhao, who's our assistant medical student. Many thanks.
Thank you, Shefta. And so our final late-breaking abstract presentation, also coming to us from Brisbane, is Dr. Paula Jeffries. And she's going to be presenting on image intensifier usage and radiation dose during insertion of growing screws for management of slipped capital femoral epiphysis. So take it away, Paula, and let me know when to advance the slides for you too.
Thank you. Good morning, everyone from Brisbane, Australia. My name's Paula Jeffries. I'm a final year training registrar at the Queensland Children's Hospital, and I'll be presenting this morning on the use of image intensifier during the insertion of growing screws for the management of SUFI patients. I have no declarations. In terms of the background for this study, SUFI, as we know, is the most common pediatric and adolescent hip disorder, affecting up to 10.8 patients per 100,000. And these children undergo significant treatment and radiation exposure during that. In recent years, growing screw usage has increased in the hope that we halt the progression of the slip, but don't prevent further growth of the proximal femur and the potential for remodeling. In Brisbane, we're currently using the OrthoPediatrics free gliding system, and I'm comparing that to the use of a standard static screw, which is most commonly a 6.5 or 7.3 fully threaded cannulated screw. Some patients have partially threaded screws. The aim of my study was to investigate whether there are any differences in the use of image intensifier during the surgery for static screws compared to growing screws. And like Shefta, I've utilised the SLIP registry, which in Brisbane we're a proud member of, and I performed a statistical analysis of the patients who had both growing and static screws. At Queensland Children's Hospital, we're fortunate to have Carly Bradford, a research physiotherapist who is a keen recruiter for patients for the SLP registry, and the data has been pulled from that, including the electronic medical records and the radiographic data. As Chef has already pointed out this morning, we have, or this afternoon for you folk over there in the US, we have 136 patients in our database, of which 121 have had treatment at our centre. And of those 121, 70 have had in situ fixation. Of the 70, 22 patients have had unilateral surgery, and for bilateral surgery, 48 patients in total, 96 hips. This is just a summary of the use of growing screws at Queensland Children's Hospital. Our first one was put in February 2020, and the data goes up to earlier this year. So we're putting in somewhere between 5 and 10 screws a year. In terms of just some descriptive analysis of the patients who were in the unilateral treatment group, 14 had static screws, of which half were female. The age are fairly similar, but in surprisingly for me, for the data, slightly older for growing screws. I suspect this is because that our patient cohort in the static screw extends right out to the start of when we started collecting the data in the SLP registry, and the Southwick angle is greater in the static screw group. For the bilateral treatment group, there are, again, more patients who've undergone static screw fixation. Of all the patients, there's been 7 that have had affected hips bilaterally and treated bilaterally. Approximately half or similar proportion of females, and age group, again, for this cohort, slightly lower in the growing screw cohort, and similar Southwick angles. In terms of the statistical analysis of the radiographic data, both groups of patients were pooled, and I looked at fluoroscopy time, radiation dose, and operative time. All 3 of those parameters did not show any significant difference between those patients undergoing static screw fixation and growing screw insertion. In conclusion, my study has shown that there's been no significant difference in radiation dose, operative time, or fluoroscopy time in the use of growing screws compared to static screws. In terms of pitfalls of this study, there are compounding factors in terms of radiation dose, and things to look at perhaps in the future when the cohort is larger would be the level of experience of the surgeon as the lead operator, the table type, and the BMI of the patient. For our SLP registry, BMI data is missing in about half, and we think that nursing staff on admission with these children into the hospital are reluctant to get the child to stand up against the wall for a measure. In terms of the future directions, as we continue to recruit patients to the SLP registry, developing a larger cohort, and perhaps utilising screw fixation more commonly, particularly in the younger children, the larger cohort could allow a multivariate analysis to see if any of these compounding factors influence a radiation dose. And once again, thank you to the research team at the Queensland Children's Hospital.
So thanks very much to all of our speakers, particularly in this engaging late-breaking abstract session. And I'll turn it over back to Al, I think, for the closing remarks.
Thanks, Emily. So let's move ahead. And I'd just like to bring everyone's attention to Hip Health Day, which is going to be held on the 2nd of June. The time will be decided soon to make it more convenient to people from across the world. But just to remind you all that we still have an opportunity to nominate someone as a hip legend. I'm sure all of us know people who have done a great amount of work in pediatric hip health, whether it's a pediatric orthopedic surgeon or whether it could be a parent advocate, a group of people who are working in hip health for children. And we're keeping that open till, the end of today. So if you take a photo of this QR code and you can put in a nomination for someone who you think is a hip legend from your city, your country, or someone whom you know. Kishore, you want to add something? Sure.
And the nomination link is in the chat.
We have with us today one of our inaugural hip legend, Dr. Tony Cooper, here, and big round of applause for him. Actually, showing all of what he has done for pediatric hip health. Thanks, Tony. Really, as the saying goes, you stand on the shoulders of giant, and you've certainly been that in this field and inspired many of us. So, thank you for all of your contributions and still being here with us and encouraging us. Thank you, thank you. Next slide. I'd like to really invite those of you. So we've got a few things going on. One is we have a registry program update, which will start at 4:30. So just go outside, and Regina has got drink tickets. Everybody gets one. If you want to have more than one, then you got to buy yourself. As per our university rules, we can't go more than one drink per person. But you are also, really want to thank, I think, the two major sponsors that have actually made this happen so far. One is our Peterson family. It's a family based out in Vancouver that truly cares about globally improving care for children's hips. So who have donated a large sum for us to be able to do this work that we're doing right now. And I'm a Hippie has been supporting a lot of the work we do for a number of years. So they're starting a new campaign called the May Mobility Month. And who here has Instagram? Can you raise your hands? Who here posts, other than your family stuff, some professional stuff on Instagram? Can you raise your hands? So I'm not imposing anybody to post if you don't, but if you do, they have a mobility challenge, which is you do any activity of your kind that you feel it's a fun mobility. Any guesses? I'll give them 3 drink tickets. If somebody can guess what's my famous mobility move is. Anybody? No, not the Vancouver team. Anybody? Sorry? Squatting, yeah. If you put a good electronic dance music, I'll squat all night. So that's what I'm going to be posting, my mobility. And I'm going to nominate between 5 and 10 people to do the same. And then with a hashtag mobility matters, with a hashtag hip health for all. So if any one of you are going to do, I got mine today, this beautiful hippie water bottle. Go and see Regina and say, hey, I'm going to follow you on Instagram and I'm going to do a mobility challenge. I think let's make it count in this month. Let's get this going viral based on our hip hop network. If you want to indulge yourself in social media, I think it's a good cause. So go see her and let's make that actually happen. Let's make Mobility Month happen. Thank you. I really want to have a big shout out to a lot of people that have done amazing amount of work, but especially Tamara. Thank you. And Joel and the rest of the Vancouver team. So thank you for the amazing work that you put in to make this happen. So, hey, enjoy the break and we'll reconvene back for our registry update at 4:30 here. Okay, thank you. Go see Regina for drink tickets.